what I think is the future. What are some approaches, and and we can generate some discussion. So very briefly, radiotherapy was based on the premise of the old radiotherapy series of 30 to 40% local recurrence rates. And for my last 20 years, I've felt like this poor bastard down here, you know, saying with good surgery, you don't need radiotherapy. And that's been my life as a radiation oncologist, being picked upon trying to recommend radiotherapy for rectal cancer. And when you look at the Dutch TME trial, which is meant to be look at the good quality surgery, you can see that the local recurrence rates had reduced from 30 to 40% down to 11% with TME surgery. So seeing a good surgeon is by far much more important than seeing dodgy Dr. Kneebone. Now, this subgroup analysis of the Dutch TME study, there's a couple of points that I want to take home and the way things are changing. One, for higher rectal cancers, local recurrence rates above 10 centimetres are only 6%. Very hard to justify radiotherapy when you've only got a 94% local control. But what I think is sometimes lost in our MDT, that even in a Dutch style, if you had node positive disease, you still got a 21% risk of local recurrence, which I think is too high. And I think radiotherapy does have an effect by, as well as shrinking the primary tumour, improving resectability, sterilising nodal disease when there are nodes involved. And again, there's a very similar trial, not often quoted, the MRC trial of short course versus selective post-operative radiotherapy. And again, for tumours above 10 centimetres, 6% local recurrence rates, higher rectal cancers, we don't really want to treat those sort of characters. For the node-positive patients, and when you look at the criteria, the MRC trial did have earlier stage rectal cancers. They still had 15% rates of local recurrence for node-positive disease, which again, I think, getting too high, 1 in 7 risk of local recurrence. This has been the bane of my existence, and I've used to try to hide the knowledge of this in any sort of talk, but you know, bring out the problems, and let's face them, is that there's a Dutch study, the risk of radiotherapy complications, and it's something we have to be very conscious of. Wound complications, apart from perineal wound, leak rates were identical, but perineal wounds slightly higher. But part of you see fecal incontinence, 62 versus 38%, there were quite high rates of toxicity with the addition of radiotherapy. So we've got to be careful with this and selective with the use of this modality. So we had those short course sort of trials, and then came the German sort of trial, and this changed management drastically. And that looked at preoperative versus postoperative chemotherapy. And you can see that preoperative radiotherapy reduced the risk of local recurrence down to about 5–6%, and that has to be our target with rectal cancer. Get local recurrence rates down to 5 to 6%. So preoperative is better than postoperative. And I suppose in the German trial, they had 14% risk of local long-term toxic side effects. Then comes the question, you've seen the preoperative short course versus chemoradiation, and I get asked this all the time about which is better, short course or chemoradiation. Australia was meant to answer the question around the world with the TROG trial of preoperative short course versus chemoradiation. And unfortunately, it shows the dangers of underpowered studies. This trial has taken both ways around the world and hasn't answered any questions, even though we were all contributors. 326 patients. Overall, the local failure rate was 7.5% in the short course versus 4.4% in the long course. So you may be a trend. In the lower third of the rectal cancer, 12.5 versus 3.2%. So the Peter Mack approach, the principal investigator, said for lower third rectal cancers, we don't give short course. Other people say, well, it's not statistically significant. The two are equivalent. So this trial really hasn't answered many questions because of the underpowered nature. It's interesting though, with better quality radiotherapy, the grade 3–4 toxicity is only 7% with contemporary radiotherapy rather than that was seen in the Dutch and the Swedish trials, which really had poor radiotherapy techniques. So at the moment, my brief is where are we now and where are we going in the future. So I'm just very brief where we are now, but basically this is the approach that we sort of say. We divide tumours less than 5 centimetres from the anal verge. We don't give short course at all to anyone less than 5 centimetres. If they're full thickness T2, T3 or our bigger lower third, we recommend preoperative chemoradiation. And I think we're all fairly comfortable with that. For the mid-rectal cancers, 5 to 10 centimetres. If they're an early T3, maybe some equivocal sort of nodes, but well clear of the mesorectal fascia, I'm completely comfortable with short course. You get to pathologic staging, you know what the nodes are doing. Comfortable with short course radiotherapy if the mesorectal fascia isn't compromised. If it's a bigger, ugly mid-rectal cancer, then we obviously go for the chemo-RT. When they're more than 10 centimetres, it's only the really big, ugly cancers that are close to the mesorectal fascia where the surgeon says, I'm worried about cutting this out, that I recommend preoperative chemoradiation. So that's where we are at the moment, and I think that's reflecting a lot of common practice around the radon communities. Now, this was how I gave radiotherapy just 10 years ago, and is all of the clinical trials gave radiotherapy. We had our coloured pencils. Stephen Clark was trained like this. He thinks that all radiotherapy is given like that. You don't know where the rectum is, you don't know where the small bowel is. You just put your box in there, and you hope that box treats the right area, and if it's got sort of critical structures, you're in a bit of trouble. And that's all the toxicity in those trials use those sort of techniques. And in fact, the Swedish trial was front and back, so you treated a small bowel regardless. This is still standard treatment across the country at the moment, is what we call conformal radiotherapy, but actually giving a box, but you can see what's inside the box. And I still think we can do a lot better, because a lot of the shape that we want to treat is like concave. And we now have radiotherapy techniques, and we can deposit dose where you want to, where nodes are unresectable. We can do sexy things with radiotherapy if you want us to. And what we need a little bit of guidance is, when do you want sexy radiotherapy? What needs additional dose, what doesn't? Let's work together to get a little bit of guidance. And so we have the technology and the tools to do those sort of things. Now, where to the future? We've been doing cone beam CTs to verify the position, but after a while, we do regular cone beams to assess the position, but you can also do scans during treatment, and you suddenly see, crumbs, a percentage of people, the cancer shrinks. And you see that shrinkage actually, we're always told you can see the shrinkage 6 weeks after radiotherapy is finished, but there are a group of people that shrink early. And you can see quite clear shrinkage. We draw in blue where the cancer is, and you can see that the cancer is getting smaller. And Sarah Cruikshank very nicely reviewed some of for a few years of patients. She said, if you had no shrinkage at 2 weeks into treatment, we didn't get a single pathologic CR. If you did get shrinkage, and part of the reasons why we haven't published this data, because Sarah and I looked at the reviews and said, that's shrunk, and we didn't get independent radiology review. It's hard to quantify it, but we just said, look, that's obviously smaller. If he was obviously smaller, it's got 44% pathologic CR. So those early responses, I'm confident, are predictors of better outcome. And this is the PRISM trial, and part of my pitch is maybe we should do this across Sydney. I know Liverpool are doing a similar sort of trial. It's taken us a year and a half to get this. I just need the signatures of Andrew Montague. And then this trial is ready to launch, and I very much appreciate the people like from Ed and Michael Chu, and there's been many people involved to get this off the ground. But what we basically want to do, all our rectal cancers, we do a PET and MRI pre-treatment. We've got 100 grand of trust fund money to pay for all the scans. We do a scan at 2 weeks into treatment. And what I'm hoping is that Ed, incredibly smart man that he is, will look at three parameters. One, does the tumour shrink? That's sort of gross shrinkage. 2, does the SUV, does the uptake on the PET reduce by 50% or whatever? And 3, does the fusion change in the MRI? I'm hoping that I think with just gross shrinkage, you can tell 44% PAT-CR. If you add all 3 together, we'll have really good predictors of those who respond well and those that don't. And how is that going to make a difference? So I'm a firm believer, and I think a lot of the data is pointing to that with clever nuclear medicine doctors, with clever radiologists, MRIs, that at 2 weeks into treatment, you can predict the responders and the non-responders. And what we want to do, and Nick Pavlakis is helping us and Stephen Clark with this, is if they don't respond, if they're big ugly cancers, what do we do? Do we increase the dose? Do we give a biologic? Do we give all the chemo beforehand? How do we intensify our treatment? And we've got a few phase 2 trials approaching. And for those that are responding, can we avoid surgery? And I'll show you, I went to Astro just 2 weeks ago. Stephen Clark noticed my absence from the GI clinic on Thursday afternoon, but I was learning stuff, and I'll be able to impart this knowledge upon to you. And you carrying the clinic was worthwhile because I learnt this sort of study, Stephen Clark. So no need to complain. So this was a French trial of local excision versus total mesoexcision in patients with good response with chemo or radiation. So basically, and I'm wanting to see if we can get enthusiasm for doing this either across our North Shore campus or across Sydney, but basically rectal cancer less than 8 centimetres, T2 or T3, they staged them with ultrasound and MRI scan. They had to be less than 4 centimetres, so probably patients would go straight to resection normally. And so basically, and you know, they have the virtual web meeting, so I've screen dumped, so the slides aren't so good. But basically, they 25% had a poor response, and they went straight to resection. So, but 3/4 of people had a good response, and they defined that clinically, just the tumour going from 4 centimetres to less than 2 centimetres. If you had a good response, then you were randomised to a local excision alone or total mesorectal excision. So can you get away with a local excision in this group of patients? Not everyone adhered to their assignment, but that's real life. If you had a local excision, the plan was if you had pathologic T0 or T1, so good regression and no muscle invasion, then that was it. If you had a TME alone, if you had pathologic T2, so you saw muscle invasion, then you say, look, that's not safe, then you cut out the cancer and do a total mesorectal excision. Now, so what they actually found that overall 40% of the good clinical responders, so those who had shrinkage at the end of treatment, I think we can do better by shrinkage 2 weeks into treatment, but for them it was shrinkage at the end of treatment. If you had, they had 61% of people that were pathologic T0 or T1 that had shrinkage during treatment. What I found fascinating is this next slide. If you and this supports what Ed was talking about beforehand, if you had good shrinkage of the primary, so your pathologic T0 or T1, then you had a 0% risk of nodes having cancer. So radiotherapy, if you could shrink down the cancer reasonably, the primary, then it was pretty good at sterilising small volume nodal disease. Justin Evans has always spoken to me that nodes are more sensitive than the primary. That's been one of your mantras. If you had pathologic T2, you had an 8% risk of having nodes involved. PT3, you had 40% risk of nodes involved. So their answer is for patients who are showing a response, risk of positive nodes, if you had PT0 or T1, you had 0% risk of nodes involved, 8% for T2, T3, 40% risk of nodes involved. And obviously if you've got nodes involved, you need the nodes removed. And so their conclusion, local excision for good responders is a promising strategy. I was sitting next to John Percy and asking his opinion, if we were to set up this study, what are surgeons concerned about doing a local excision after chemo or RT and healing and those sort of issues? To me, that's the main sort of issues. This is a presentation in Astro, they haven't talked about a lot of those issues. But so basically, so they're saying for selected T2, T3, less than 4 centimetres, 75% have a good clinical response, 61% achieve a good pathologic regression. And so to me, that's where maybe a group like this, we can start testing novel approaches. So my attitude is don't regard radon as your enemy. With MRI and PET, I'd love biomarkers, and part of the PRISM study, we want to collect tissue, we want to collect serum, we'd love to have, c-MYC positive, and that'll tell us the answer. But until that comes, we're going to rely on MRI and PET and imaging modalities to assess those that are likely to respond. And so I think there's a real trend moving away from radiotherapy for rectal cancers or even early T3s that are well clear of the mesorectal excision. We've just got to accept that the risk of local recurrence for those is going to be in a 5 low percentage, and so they're not the ones we're interested in. Instead, we'll gain the early ones and get the good responders and avoid surgery. So we'll give away some, we'll take others. So we'll work towards that. I'm a firm believer that you don't irradiate the anal canal, and I don't think in our hands we get anal leakage like that's reported in a Dutch study, and I haven't really got my fingers burned avoiding radiating the anal canal, which I do. So my conclusions in my 10 minutes, support PRISM.
7 minutes ago.
Yeah. Support PRISM, and if we want to expand the collaboration, be keen as mustard so we can get these results quickly so we can work out the next progression. So that's where we do a PET and MRI 2 weeks into treatment, and for completeness sake 6 weeks afterwards. I reckon right now be really nice if we can start developing a surgery avoiding protocol for low volume T2, T3 disease, collect prospective data and try to identify which patients that we think that approach is safe. I think that'll be a novel approach for this group here. And what I'd recommend is give 2 weeks of chemo-RT for rectal cancer. We do our PET and MRI after 2 weeks. If there's good response, then finish your chemo-RT, do a local excision. If it's pathologic T0 or T1, then local excision is not. If you do a local excision and there's more pockets of disease in a muscle, then you do your complete resection. If poor response after 2 weeks, we abandon our chemo-RT and just proceed to a resection that's not doing any good. Now, and also I think we should try to do an aggressive approach for the big ugly cancers, which are the bulk of what we see. If we see a big ugly cancer, we do chemo and we do a PET and MRI and it's not responding, and you go, shit. Not that you guys would ever say shit, but I do.
Can you spell it for the people?
I'm being videoed. Lovely.
Forget to tell you that.
Yeah, so yeah, no, thanks for that. Thanks, Dr. Engel. Yeah. If you're not responding, then I think you then consider you could either dose escalation, add a biologic, maybe give all the chemo, Folfox beforehand. They're aggressive tumours that I think are nasty cancers. We've got to work out an investigative, aggressive approach that maybe we can compare with standard chemoradiation. So that's where I think we should try to head as a group. I think that's achievable right now, and I think I was saying to John that I think we're now ready as a unit to start progressing these sort of protocols and be novel, and so we can get some people to stand at conferences in the future and say, look, this is the North Shore approach or Sydney approach. That'll be from my perspective. So thank you very much.